Go ahead and start up. Hi everybody. My name is James. I am a physician assistant. A little bit about me. I did my undergraduate work at George Washington University. I went to Stanford Medical School for my PA training. I was in the Navy for 20 years, where was practicing primary care and emergency medicine. After I got out of the military, I went into neurosurgery, and that's why I still practice to this day. I'm kind of the founder of this program we call it's Physician Assistant Mentor Online, where we help pre-PA students. But for today, we're just doing virtual shadowing. For some of you, maybe having a hard time finding shadowing. Anyway, there's a couple of PAs that I've known over the years, so I'm just going to go ahead and let you guys introduce yourself. One is a student I worked with a couple of years ago and just graduated. Was it December of last year or January? Okay. So, Kristen, if you want to go ahead and introduce yourself and
Yeah, I'm Kristen Gunnison. I am a cardiology physician assistant. I've been practicing for about 8 months now. I went to Chapman University here in Orange County. And like James said, I recently graduated in December of 2024.
okay. And then today's host, somebody I knew a few years ago, not that long ago, but I think just, we were talking about earlier, just probably shadowed me a few times in my office when I worked back in Southern California. But Georgina, if you want to go ahead and take over.
Yeah, hi everyone. My name's Georgina Rye. I am a physician assistant. I currently work at Planned Parenthood of the Pacific Southwest here in SoCal. I am their manager of clinician training, and I also do their ultrasound program services as well. And then I work per diem at a urgent care, primary care. And I'm so happy to be here with you guys. Very excited to share a little bit more about what I do at Planned Parenthood and can answer any questions about women's health, primary care. So just let me know.
How about if you just real quick tell everybody like what everybody wants to know too is like, why'd you become a PA and how'd this start out for you?
Oh yeah. So I went to PA school back in 2014. So I've been a PA for 8 years now. When I was in undergrad at San Francisco State, I was heavily involved in like health education on campus, primarily of sexual health and reproductive health. So I did a lot of counseling in the health center on campus with students one-on-one with like STI testing recommendations, birth control testing recommendations, and I loved the educational aspect. But after that, I would then have to kind of like help schedule them an appointment with either a PA or a nurse practitioner. And I was like, wait, like that's what I want to be doing. I don't want to just be educating the whole time. I want to be able to take care of these patients and kind of follow them like through the rest of like their healthcare. So that really just prompted me to continue my undergrad degree at San Francisco State doing biology. After graduating, I returned to Southern California and I worked as a EMT, getting my hours, did my internships, at Palomar Hospital in Southern California. I shadowed James for a little bit to get, used to different so-called specialties as a PA because there's so many different routes you can go down. And I just love the autonomy that PAs could really hold in the field. And so yep, worked with James, worked really hard, did a lot of shadowing, extracurriculars, and got in my first cycle at Toro University in Northern California in Vallejo. So I got my dual master's up there, so master's in physician assistant studies and master's in public health, specializing in global health. And I do a lot of like HIV work and STI prevention at Planned Parenthood as well. So it's great to have the diversity in the field to kind of do kind of everything you want to do. Like I get to do my urgent care and then I get to do my women's health and then I can still do public health work. So it's been really great.
Okay, I'm gonna go ahead and start off your presentation.
Sure.
So we've
All
done
right.
the
Yeah.
we've done the introduction.
All right, so I put together a little PowerPoint here, and we're going to walk through kind of like a case study that you might see. And this could actually be either at urgent care or at Planned Parenthood, and it's around pelvic pain. So today we have a 25-year-old female presenting with pelvic pain for 1 week. And so what I wanted to kind of start off with when I teach or like have a student is kind of thinking about the differential diagnosis before you walk into a room. So it's like, okay, my patient's 25 years old. they have pelvic pain. What are like the top things I think is going on with this patient? What are some things I want to make sure I'm not missing with this patient that could be red flags, that could be emergent? So we're going to talk about that. We're going to talk about best practices for gathering a history, when to order specific in-clinic labs, how to evaluate your patient, which then leads to your assessment and plan. Next slide. So I know this is a lot of words on the slide, but I was trying to break it up into categories. And so for pelvic pain here, we're kind of thinking about, all right, is this infection? Is there a structural abnormality going on with my patient that's causing her pelvic pain? And then you always want to kind of think about the don't misses or red flags. That's like, okay, if I miss this, someone take away my medical license because that was a really bad miss. So infectious wise, we're thinking of like pelvic inflammatory disease. Did my patient recently have some sort of gynecological procedure that could have caused a perforation that's now giving them pelvic pain? Is this truly pelvic pain? You'll learn a lot with patients that they'll say something, but I've had patients then point to their upper belly and I'm like, okay, pelvic pain is, usually a little bit lower. So it looks like you're pointing to your gallbladder. So is this truly pelvic pain or not? So sometimes on the differential, you think about above and below the system. So just don't want to miss anything related to the bladder there. Was my patient recently pregnant or not? Is she having any symptoms that could like be complicated from a recent pregnancy that could then be like endometritis? And then structural, seeing if it's around, menses is causing her pelvic pain or not. Is it one-sided? Like where is her pelvic pain? Because then we start thinking about like fibroids, cysts, endometriosis. Urinary calculi or like a kidney stone isn't very high on my differential for young female patients, but you don't want to miss that either. And then things you don't want to miss that your patient in front of you isn't pregnant and is having a, bursting ectopic, any sort of abscess inside their pelvic region or a torsion where their ovary could twist on itself. So there's a lot of like high level things you're doing before you even walk through the room. Like you're thinking about all these things and then you're going to like move them up and down your list as you start asking your patient questions. So let's get a little bit more info from our patients so we can start thinking about how to move these diagnoses from our list. So next slide. So a little bit more information. We took a really good history with our patient and we found out that it's a dull pain. It's midline, so it's in the middle of her belly, 4 out of 10, not super concerning, 10 out of 10, like ER situation. It's non-radiating, and then she's also having some associated signs as well. So she's having discharge and, quote, feeling warm. I can't tell you how many times my patients tell me they have a fever and they said, oh, how do you know? And they say, oh, I just touched my hand to my head. And I'm like, okay, so it's always good to differentiate what a fever means. No nausea, vomiting, fever over 100.4, as we confirmed today in the center. Actually, we didn't get a temp. We should have got a temp. Upper abdominal pain, painful urination, no blood in the urine, no frequency, and no vaginal bleeding or diarrhea. So some discharge, feeling warm, midline pelvic pain. She's tried some stuff for her pain. Looks like she took Tylenol, 1 dose with minimal relief. She's never been tested for sexually transmitted infections. She's had a new partner about 6 months ago who's also experiencing some symptoms, which is a little suspicious. And she sometimes uses condoms. Vitals look okay right now. Oh, 99 fever, sorry. So nothing out of the ordinary, maybe like slightly elevated temp, but nothing concerning on the vitals end. Looks like she just recently had a menses on 9/1, so about 8 days ago. She's a history of a appendectomy, so we know nothing's going on with her appendix because she doesn't have one. No meds and no allergies. So next slide. So some things we can do in the clinic right away is we can do a urine pregnancy test. She sometimes uses condoms. Yes, like she had her period recently, but we always want to make sure we're ruling that out. And we can do that today in clinic. So she's not pregnant. At Planned Parenthood specifically, we have microscopes so we can perform what's called wet mounts, where you take some of the vaginal discharge, you place it on the slide with KOH and saline, and you can kind of see if there's red blood cells, white blood cells present. Do we see evidence of candida or a yeast infection or bacterial vaginosis? And you can see here, we did do a slide and she does have some white blood cells. White blood cells are very non-specific when it comes to vaginal discharge. It shows like, yes, there is maybe an infection going on. It's not a diagnosis. It's just kind of supporting like either an inflammatory or an infectious response. So that's giving us a little bit of information. And then an exam is very important as well. So she's alert, oriented. She's a soft abdomen. There's no rebound or guarding. So I'm not like concerned that there's like maybe sepsis going on or anything like kind of expanding from her pelvis. She does have some tenderness over her uterus and her adnexa or over her ovaries with the bimanual exam. And she does have something called cervical motion tenderness, which is when you manipulate the cervix, she is just jumping off the table. It's not, that's a red flag. So, and then she's also having some copious green discharge. So signs and symptoms of infection here are definitely apparent. So let's go back to our differential with the next slide. So now we're kind of like crossing things off, right? Like I don't think she's not pregnant, so she's not having an ectopic pregnancy. If she had like a torsion, she'd be 10 out of 10, one-sided pain. She wouldn't even be in my clinic. She would be in the emergency room. Structural, she might still have some sort of structural thing going on, but it's not the highest on my differential because of all the white blood cells I'm seeing, the copious discharge, the tenderness. So she's having a lot of inflammation going on. So I'm going to diagnose my patient with pelvic pain today, very suspicious of pelvic inflammatory disease. So next slide. So with this pelvic inflammatory disease, what I like to also teach is making sure that you're also putting your supportive evidence inside of your note. So if like she goes and sees somebody else or she's coming back to clinic for follow-up, the other provider that maybe might see your patient can kind of see like where your thought process was when you were diagnosing and working up your patient. So this patient had those white blood cells we talked about, negative pregnancy test in clinic that day you saw her, and then just like a very like sensitive exam when it came to examining the cervix, uterus, and adnexa. She's at risk for STIs because she's had new partners, and so she's meeting the criteria for PID today. So obviously pelvic inflammatory disease is kind of like non-specific. It's more just like there's a lot of inflammation going on in the pelvis, right? So we do want to know exactly what's causing it. Most commonly for patients under the age of 30, it will be an STI. So we definitely want to make sure we're doing STI testing today. So we'll do gonorrhea, chlamydia, trick testing. And then I also like to throw things into my note, kind of like we'll consider maybe imaging at a later time if the pain persists, or like let's say we treat her for pelvic inflammatory disease, she's feeling a little bit better but like not completely better. We don't want to miss that she might also have like an underlying structural cause of like pelvic pain as well, so maybe consider that in the future. And then we'll do CDC recommendations of treatment here. So ceftriaxone, that usually covers the gonorrhea, doxycycline that covers chlamydia, and then metronidazole that will cover the tricks. So we're just going to cover all bases today and treat her for all of the most common STIs as well. And then usually our protocols at Planned Parenthood are to make sure that we follow up with this patient in 24 hours because we want to make sure they're improving, right? So we want to see them in 24 hours, repeat the exam. If they're not feeling better or their vitals are abnormal or something is going on, we'll then have to refer them to the ER because they're failing treatment with us today. We always want to give our patients ER precautions as well. So, you know, if you get a fever at home over 100.4, or you're having pain that's so bad that you can't get out of bed or go to work or do your daily things, definitely go to the emergency room, because just because today you didn't have sepsis or something more serious going on doesn't mean that that may not happen ever. So we just want to precaution them. Like if anything gets worse, this is what you're supposed to do. So just like a high level overview of like kind of working up the patient at the end is like, this is what's happening today. This is what we're doing. Call us or go here if this happens. Next slide. And then just a little about pelvic inflammatory disease. So PID is pretty common. Prevention is always best. And I think this is something I really like to hammer home when I'm doing my primary care. I mean, yes, I do prevention all the time when I'm working at Planned Parenthood. People know that they're coming in and probably going to get STI testing. There's a lot of, not lack of, but I would say comprehensive sexual health histories aren't always taken at primary care or urgent care. So it's always really important to make sure that you're taking a very comprehensive sexual health assessment on your patients. Like, are you having sex? If yes, where are you having sex? When was the last time you were tested? Let's make sure we're not missing any sites, and making sure that they're coming in routinely and getting tested, even if they have the same partners, even if they're married, just because CDC recommends at least once a year. And the reason for that is a lot of these STIs are asymptomatic, right? So a lot of people don't always know that they have a sexually transmitted infection, and the complications can be PID, which we just saw, right? Someone coming in just all of a sudden having pelvic pain. More serious can cause like an abscess in the tubes, increased risk of infertility and ectopic pregnancy. So it's really good if people are planning to have families in the future that they have this routine testing, because ectopic pregnancies are can occur if you've had STIs. Considerations to always kind of think about for PID: if patients have an IUD in place and symptoms are persistent at that follow-up, to remove it. And then just a little bit of the prevalence here. 4.4% of folks 18 to 44, and approximately 2 million people self-reporting a history of PID. So again, we really want to make sure patients aren't getting these complications as well. So just a little overview, but the disease can really cause some of those adhesions that you see circle there, or scar tissue in the tubes and in the reproductive tract. Next slide. Oh, and I think that was my whole presentation.
Okay. Let me go ahead and go back to the screen. Okay. So let me see. I God, I always kind of forget how. All right, they should be. So for anyone who has any questions, please feel free to, I guess, type them in, and we'll go ahead and. Oops, it's not. Here we go. All right, Kristen.
Oh, it's in the Q&A box, isn't it? Okay, so Gabriella wants to know, how did you find your MPH to supplement your role as a PA?
Great question. I would say a lot of what I'm doing at first, I feel like my public health master's was, yes, it was there. It was great to have. It was a great experience. But I feel like my initial goal out of school was to be a clinician, right? It wasn't until I would say like the last couple of years that I really started using my master's in public health to really start building my career more. So now I'm more involved in community-based projects, like working with HIV prevention specialists in the community, being a huge advocate for PrEP and HIV prevention, starting initiatives at Planned Parenthood for, reaching goals of STI testing, and putting together presentations and educating. But I would say the biggest thing I use my public health degree for is educating. It's always been something that's like really near and dear and close to me. So I use that as like a teaching opportunity and a way to get more involved in my community. Good question.
Okay. So, don't be shy, people. If you want to ask
Yeah,
questions,
ask me
this is
questions about Planned Parenthood or like women's health. Is
okay.
anything you're interested
Okay.
in?
Here they come.
Sorry if I don't pronounce your name right. Summit said, given the current political climate and funding cuts, what has been the biggest challenge to manage as a provider?
Great question. So I live in California where we have a lot of, I wouldn't say freedom, but I mean, yeah, we have freedom, but it's more like nothing has changed here in California. Yes, we are always kind of like keeping an eye on what's going on. So I would say the biggest challenge for me is to reassure my patients that we're still here to take care of them regardless. So if patients are coming in for abortion care, if patients are coming in for gender affirming care, it's really just letting patients know, like, we are here for you. We will make sure we get you your medication or your life-saving service, no matter what, and we will help you with any other socioeconomic support. We have a great care coordination team at my affiliate as well. So it's just about reassurance and just making sure patients know, like, right now we're good. Come in, we can help you, and we will just kind of take it one day at a time.
Okay, Miriam is asking, how did you decide NP versus PA?
Um, Good question. I think it really just kind of came down to like where I was initially when I learned both about being an NP versus a PA. I met more PAs than I did NPs. I also had done a lot of research, and I don't know how much has changed since, I don't know, 12 years ago. But a lot of people do become a nurse practitioner after like being a nurse and like going to nursing school. And so I was kind of going down a different path and a different road. But I work with so many nurse practitioners. I train a lot of nurse practitioners side by side with PAs, and we are very autonomous in our clinics. We run the clinics here at our affiliate. We don't have any doctors on site at our family planning centers. So, I mean, yeah, I guess that's me answering your question.
Okay, Shiza wants to know what made you choose this specialty.
Oh, women's health specifically. I mean, I've always been really in love with reproductive health and just destigmatizing sexual health, STIs, abortion care. I think it was something I was really drawn to in San Francisco with my undergrad. Part of like my undergrad like degree was I did a lot of like sexual health as well. So just like learning a lot about sexual health and advocating for it, it was just like a really natural progression to go in and help support women just feel super safe, like using a trauma-informed lens and just letting them know like they're exactly where they need to be. And I'm like there to help them do whatever they need today. Just wanted to create a lot of safety.
Okay, another question. Esther said, how many other PAs work at Planned Parenthood? How is your role different from a physician or an NP?
Yeah, so at my affiliate, we have 19 health centers. At all of our health centers, it's primarily nurse practitioners, PAs, certified nurse midwives, and then at our surgical sites, with the more like advanced procedures and surgeries, our doctors work there. So that's the main difference. And then I would say from like a supervising physician standpoint, I do have my charts reviewed, like per policy. And then if there's ever like a situation outside of the scope of our medical protocols, we have an MD on call every day. So we just can do an MD consult, and use that support as needed.
Okay. Andrea wants to know, how do you approach sensitive topics pertaining to fertility, sexual health, etc., with patients?
Yeah, I think normalizing is the biggest part, is just like normalizing. I think some people just get really anxious and nervous, and just letting them know like, this is my everyday. And so like you're in a safe environment. I also always take my patient's lead. So if someone's feeling more anxious or nervous, or I always ask them like if they've ever had this type of exam before, service before, like, do you want me to explain every step of the way? Do you not want to? There's also a lot of different ways to approach trauma-informed care, a lot of like research you can read about how to advocate for your patient or how they can advocate for themselves. Like they can insert their own speculum, they can like say no. It's like I think just like putting the power back into your patient's hands is like one of the most empowering things you can do for these folks.
Okay, Melanie asks, what is a challenge you have faced being a PA that you didn't expect or wasn't talked about?
Ooh, that's a good question. I think no one really talks to you about that transition. So it's like you come out of school, you take your boards, you're like, great, I'm a PA. And then you get and start working and you're like, you just want to do everything because you're like, oh, like I'm so new. I just want to like make sure like I'm doing everything right. And so I feel like that imposter syndrome's there for like a while. Like, oh wow, my patients are really listening to me. I'm the one that's prescribing all the medications and taking care of folks. And then just like learning how to delegate things to the rest of your team, like using your medical assistants, like working together in that regard. And then also, I think no one really talks about like after you become a PA, it's just so interesting because I worked so hard to get into school and then I became a PA and then I was like, okay, like what's next? Like I was always like on the move to do like that next thing. So yeah, I would say like that's the thing there. Good question.
Ayana is asking, what advice would you give to undergrads or things that they should know before pursuing becoming a PA?
I think just dabble in everything. I think just really having so many different types of experience and just really picturing yourself as a PA, you know what I mean? Like what would your everyday be like? Like why do you want to go into medicine? Like what is really something that you're passionate about? Like don't do it because it's like the number one job in the US, which is also like a great thing, but do it because like it's going to be something you're going to be doing for the rest of your life. So I think it's something to really sit back and be like, okay, this is going to be probably a lot of money. It's going to be a lot of hard work. Is it worth it? And then just try to imagine your life and what makes you happy.
Okay, Shimra asked, what role do PAs play in improving access to preventative health services like pap smears and STI screenings?
Good question. I think access is the biggest one. I mean, like I just mentioned, we have 19 health centers and all NPs, PAs, and certified midwives work at all of those health centers, at least, we have five, 4 to 5 clinicians working in a health center every day. Every clinician has at least like 30 patients on their schedule. So just increasing access for people to come in and get services that they need when otherwise they wouldn't maybe able to get. I mean, specifically at Planned Parenthood is like we're serving our underserved patient populations. Like a lot of these folks either have Medi-Cal or are living 200% below the poverty line. So we're just making sure that we can educate people and get them the care that they need.
Okay. Fatima asked, what's the best thing you love about Planned Parenthood?
Oh, man, just like the one thing. It's so hard. I mean, I really love my colleagues. I guess I could just start. That'll be my answer. It's just everyone that comes here is really passionate and like they are just ready for the fight and ready to advocate for their patients. And we all just have like this underlying understanding of how to help one another. It's just like a very beautiful community that we have at Planned Parenthood.
Esther asked, was your woman health rotation in PA school similar to what you are currently doing?
No, not at all. I did my women's health rotation in Reno, and my doctor didn't even talk to their patients about their pregnancy options. And he saw mostly the OB cases, and sometimes I would work with the nurse practitioner, and she would have to be the one to talk to patients about prevention and options counseling. And I don't think there was like a clinic in Nevada for like termination. So we would have to like let them know, like, if, here are all your options. If you want to go somewhere, like here's a place you can go. So it was very different. But it was still a good experience. I got to deliver some babies and I'll never forget that.
Okay, Elizabeth asked, how often do you find yourself doing preventative care versus treatments for conditions on a day-to-day basis?
Good question. So at Planned Parenthood, the schedule is very mixed. I think one of my favorite things about being a PA are all the procedures I can do. So I think it's just based off of our templates. So our templates at Planned Parenthood are mixed. So we'll see a combination of like pap smears, breast complaints, Nexplanon removals, IUC inserts. We'll do endometrial biopsies, vulvar biopsies, abortions, pregnancy tests, STI testing, birth control. So it's a very large service mix, and every day is kind of like, like the general visits you'll see, but you'll see definitely like different things with patients. Like you might have like 4 pelvic pains one day, or the next day you might have no pelvic pains, but we'll see a mix of preventative and diagnostic on a day-to-day basis.
Okay, Hadriana asked, are there procedures or skills unique to women's health that you didn't expect to use so often as a PA? Also, how do you handle sensitive conversations with patients who feel nervous?
Are there procedures or skills unique to women's health that you didn't expect to use so often? I don't think there's any specific procedures or skills that I didn't expect to use so often. Something that we just started implementing at our affiliate are paracervical blocks for IUD inserts. So that's been something new that we've been doing, which has been great. But yeah, I think I expected to do IUDs. I expected to do implants. I guess endometrial biopsy was something I didn't really like think about I would be doing so frequently, or vulvar biopsies. I always kind of thought that was not going to be something I was doing, but it's really fun to do those things. The sensitive conversations is more just like shared decision making with patients. It's like, what's making you feel this way? Like, tell me a little bit what's going on, having a very like open dialogue, letting them know like how normal it is to feel anxious or nervous. They can stop the procedure, or, take a pause whenever they want. Is there anything that might make them feel better? Do they not want to do anything today? Do they want to come back? Would it be helpful if they listen to music? We dim the lights. So there's a lot of different ways to help support patients during sensitive conversations. Or I guess I was talking about procedures, but sensitive conversations is more just, letting them know that, you know, it's okay to ask a lot of questions, and I can help clarify if anything doesn't feel understood.
Fiona asked, what are the biggest challenges of your job?
Appointment slots. That's something that I guess was a big like, oh, wake up call when I came out of school too. It's like, oh wait, I have 10 minutes to do all of this in one visit. Okay, great. So we have 10-minute slots for a lot of patients. And like I just mentioned, a lot of our patients are very complicated, don't have primary care providers otherwise at Planned Parenthood. So they'll come in with like 10 different things that they want to do today. It's like maybe they took like a bus to get here. It's the only day they could take off work. And you're just like, well, of course I want to help do everything for you. But then it's like you get backed up. Like it's just you getting really creative about how to problem solve and help your patient in front of you, but also be very mindful of the efficiency and making sure every patient is getting like equitable care that day. So I would say that's probably one of the biggest challenges, is just like telling my patient, like, thank you for telling me you want to do this today. Unfortunately, we don't have time. Like, let's get you rescheduled to do that other thing you really want to do.
Okay, Amal asked, did you get to see something related to your specialty during clinicals?
Just that women's health rotation. But no, I didn't like do a rotation at Planned Parenthood. I didn't do a rotation at an urgent care either. I did my emergency medicine rotation in Bakersfield at Kern County Hospital. So it was like a county hospital. Um, I don't know. I think it's great that people work in the ER. It's hardcore. And I knew I like really liked it because I did a lot of EMT work, but I just didn't want that like 12-hour day in the ER, but I still wanted like to be able to help acute patients in some way. So that's kind of where the urgent care came in there.
Okay. Miriam asked, how many patients do you see a day?
Depends. So, for an 8-hour shift, it can be anywhere from like 18 to 24 patients at Planned Parenthood. And then, at urgent care, primary care, I'm on 15-minute slots. But it also depends, because the way that you'll learn when you get out into the template world with scheduling is it also really depends like what your patient's there for. If someone's there for like a procedure, your visit might be 30 minutes long. if someone's there for, a preventative visit, the visit might be a little bit longer, but I would say on average, like 18 to 20.
Okay, Stephanie asked, what is something you recommend or advise for undergrads who want to become a PA?
Yeah, I think just shadow a lot of different PAs in different fields, just to get the exposure and ask a lot of questions and just expose yourself to as many new opportunities as possible so you can really understand the roles because there's so many different types of PAs and roles out there. Like shadowing one isn't going to give you like, oh, great, I know what a PA does because there's so many different types of PAs and like I mentioned earlier, I also work in the administration at work as well. So I do like half of my time's admin work, half of my time is seeing patients. I also do like telehealth. So everyone is different. So do as much shadowing as possible.
This kind of ties into that, and you may have already touched on it, but what advice would you give regarding choosing a specialty as a PA?
Yeah, I think just shadowing as many different types as possible.
Kristen asked, have you ever considered another specialty besides women's health?
Yeah, good question. I really liked my dermatology rotation in PA school because there are a lot of procedures also in dermatology. So I kind of nerd out when I see derm stuff in my urgent care. I like pull out, I know I pull out a book, you guys. I pull out my derm book and I like look and I like find the rash and I'm like trying to figure it out. I'm like, is it autoimmune? So I think dermatology has always made me nerd out a little bit.
What would your advice be to student applying to PA school program this cycle?
Um, I think just having other PAs like review it with you, like review, like having a lot of like second, third, fourth eyes on your application, people that have maybe like seen applications before, like interviewed on like PA boards, but I think sometimes we can not be as like objective. So it's good to have other people kind of looking at your application.
Okay, Miriam asked, do you see yourself switching specialties or going part-time in the future as a PA?
I mean, I don't know in this economy going part-time, but like maybe. I mean, I really love the different things that I'm doing right now. I actually just became a gender affirming care provider. I got signed off last Friday. So I think there's always opportunities within my affiliate to keep expanding my skills and doing different things. As for like completely leaving women's health or urgent care, probably not. But yeah, I think once I get a little bit older and more tired, I definitely want to go into more full-time teaching, I would say.
Isabella asked, how was your experience at PA school?
Great. I mean, I've made some lifelong friends. We talk almost like every day. We're also like in the midst of renewing our boards. So it's always like, don't forget to renew your boards. Like how do you guys do this cycle on renewing your questions? But it's kind of a roller coaster. I'm not gonna lie. Like you get there, you're so excited, but it is long days. And I did a double master. So I was in class for 12 hours a day, right? And like every other day was an exam or a presentation. So it was definitely pushed me a lot, but I also feel like I came out with like a lot of confidence and I felt really ready to take on and see people. I don't regret it whatsoever, but
Jasleen asked, how was your didactic year of PA school? Was it a difficult adjustment from undergrad in terms of studying?
um yes, it is different. I lived with other students, which I highly recommend if you can do that. So like we studied together. We had like a dedicated study space. We had like a giant whiteboard in there. We would always sit down and make sure like we reviewed everything together. I think like the only way I honestly really got through PA school was having my study group and like holding each other accountable. Like, okay, like go take your nap. I'll wake you up. Or like, hey, I made you coffee. Like they're supporting you. They want you to succeed. You guys like become so close. So I would just say like, it's really like the grind. Like you're grinding in and out every day going to work and they're like, let's just get through this next test.
Okay, Zoe asked, did you get certified to find PCE jobs during undergrad or not?
Good question. I put a bunch of different stuff on my resume when I applied to PA school. I mean, I did my official like EMT. I was an EMT for almost 2 years. But then I also had other things on my under or on my resume or whatever application. So I was an anatomy teaching assistant. I also like volunteered all over the place, but I would say like my official one was the EMT license and the driving an ambulance for a couple years. Yeah.
Ayana asked, what is it like shadowing PAs and how are you able to find PAs to shadow?
Great. It's probably changed a lot since my day, like a lot. I think I just like Googled and stalked people. I think people still do a lot of stalking, but I think LinkedIn is like really helpful. I just had a girl reach out to me recently, and I was like, wow, yeah, great. And I was like, sure, come on in. So I think LinkedIn is really great. I mean, I think social media is really great now. And I think there's a lot of people on social media that are out there willing to help take students. So I would just go through that venue, I think. Mm.
So he asked, if you took a gap year, what did you focus on during that period?
Yeah, so I graduated undergrad. Oh, I'm gonna call out my age. In 2012. So I took 2 years off before getting into PA school. And I looked at the programs I was interested in going to. I wanted to make sure I had all the classes. I think I had to take like a sociology class for a couple programs. So I went back to school to do a sociology class. I think I got like a C in one of my chem classes. So I retook chemistry. And then I just worked as an EMT and then I shadowed and I internship. Like it was all like those 2 years, just like my big prep and just making sure I had like a really solid application before I applied.
Okay, Melanie asked, would you do anything differently if you went through PA school again?
Differently. I don't know. What do you think differently? No, because I made sure on my breaks to like have fun on my breaks and travel on my breaks. I think it's so important to have like a balanced life. I guess like I would try to have more of a balanced life. I would maybe like prioritize like the gym more, like walking more. I think like that's really important. And that's what I always give advice on is making sure to really take the time to take care of yourself because that first semester of PA school is like woo, like I don't even know, like it just goes and you like think you're just like not going to be able to make it, but you're going to make it. But make sure you're eating, you're sleeping, you're going on walks and things like that.
Okay, Audrey asked, how many schools did the both of you apply to? What advice do you have when choosing which PA schools to apply to?
I think I applied to like 12 or 15. And then when choosing a PA school, I mean, I'll tell you what I didn't do that I wish I did. I mean, yes, I like loved going to Toro. I felt like it really prepared me for being a PA, and the public health was really intriguing because I love teaching. But after I got into Toro, I didn't go to my other interviews. And now I tell people like go to all your interviews, have all your options, and then I mean, I can't tell you like which one to choose. I mean, location's great. I would say also tuition's a big one. I mean, like you're gonna be a PA at the end of the day. Make sure like you're gonna get a good degree and you're gonna be able to pass your boards. But yeah, you're gonna be a PA at the end of any program you decide to go to. I don't know what you would say, Kristen.
Yeah, I think I applied to 8 programs, 6 to 8 programs. And I think advice when choosing which PA school is like location, price, kind of the way you can do it the cheapest. It is very expensive. There are programs now that give out big scholarships. So, finding schools that really meet what you need. Also, some programs, they have different focuses. So some are surgeries, specialty schools, some are 36 months, some are 24 months. So there's a lot of different criteria, I think, that go into really picking a school. Um, I would say, yeah, that's mainly my answer.
Mhm.
Okay, Miriam asked, where and what did you do for an internship? Where and what did you internship for, and what did you research?
So I interned at Palomar Hospital here in San Diego, and it was called like a Pathmaker internship. So you could intern as basically like a volunteer. You were kind of like a CNRA in a way. You would just kind of help with like on the patient floor, like help take care of patients, like bathing patients. I worked on like the critical care floor and just there's like a lot of companionship and just kind of learning more about like what the other doctors and providers did on that floor. Um, what other internships did I do? I did that. I think that was like my main like internship that I had done. And then I didn't do any like research before PA school, but we did a lot of research for the public health rotations when I was in PA school because you have to pick a public health track, either global or community, and I did global. And I lived in Southeast Asia for 2 months, and I worked in Phnom Penh for a nonprofit doing HIV prevention. So we did a lot of research there, and I think that really helped like spark and like really solidify like my interest in HIV prevention and public health as well. Mm.
Okay. That
Well,
looks like
since there are no other questions, let me throw a couple. I know that when I talk to people, there's just always, in my opinion, this misconception of Planned Parenthood because of abortion, but yet, if my
Mhm.
understanding, it's a very small amount of what actually goes on.
Yeah, the majority of our services, STI testing, birth control. A lot of other service mixes that we see are like gynecological infections. I think a big misconception is we only see women. I see a ton of male patients as well coming in for symptoms. We do a lot of cancer prevention. We do cervical cancer testing. We do colposcopies, we do LEEPs, we do vasectomies, we do bilateral tubal ligation consultations and referrals. We see complex patients like all the time. We do gender affirming care, which I talked about. And yeah, I think we'd get a bad rep because it's,
Mhm.
abortion is like one of those topics that are very highly stigmatized in our country. So that's what I teach my new hires on the first day at provider orientation. It's like, welcome to Planned Parenthood. You're gonna now be the walking poster child for abortion. When, really we do so much more. And I think, yeah, that's very, very small service mix that we see on a day-to-day basis.
Right. That's, yeah, I just want, would you say like, I don't know if I know, like insurance wise, is it just anything or is it cash pay or?
Yeah, so we see majority Medi-Cal and Family Pack. So Family
Oh,
Pack is a program we have here in California that you have to be able to cause a pregnancy or become pregnant. You have to live 200% below the poverty level and then have like no and make like a certain amount a year to qualify. So we see a lot of those patients. We get reimbursements from the state through that Family Pact program. And then we do see like commercial insurance or private insurance, and it depends like who we're contracted with. But same thing as like going to any primary care, like there's a copay. Sometimes we see patients will come see us like who have primary care providers, but they want to see us for their like women's health
mhm.
care um, all the time. And then we do have some self-pay as well, depending.
Okay. Well, it's nice. I mean, I think the big thing, Medi-Cal, you mentioned, like other states have been Medicaid, but there's just so many providers that just won't take that. So that's great that that offers that for people who, again, like in a lower income status, but have no other alternative and where to be seen or treated.
Yeah. Yeah. A lot of my patients don't even have primary care. Like I will be diagnosing with patients with high blood pressure. If they, I make sure like I catch like, oh, like you said, like mom, dad, brother, sister all have diabetes. Have you ever been screened for diabetes? I see that you're getting recurrent yeast infections and you're saying you're really dizzy and maybe hypoglycemic. So then, we're also catching all of those potential comorbidities with our patients and getting them connected to care and just educating them on other services like, oh, I see that you're approaching the age of 45. Do you know about colon cancer screening? And just making sure that people are getting the other
Like,
things that they need that they might not otherwise know about because they don't go to the doctor.
What about, I mean, in Planned Parenthood, I I guess like what kind of barriers do you encounter like in terms of patients, other than like language? Like are there cultural things that you have to be sensitive to when people from different backgrounds coming to Planned Parenthood?
Yeah, good question. I've seen every type of culture and patient coming in for services and abortions as well. But yeah, just like you said, it's just making sure we're using a Stratus interpreter, like an interpreter that can interpret everything I'm saying. They are fully being consented and understand like what they're getting at Planned Parenthood. Um, I think that if there were to be any barriers, is like sometimes with certain cultures, it's like, oh, I want my husband in the room. It's like, no, like
Right, right.
I'm gonna have the patient come back. I'm gonna make sure there's no intimate partner violence. I'm gonna make sure my patient wants to be here. I want to make sure that they're spoken to in their language, no family members talking
Mhm.
on their behalf. So I think, yeah, we're just making sure the patients, like we're all good here, right? Like you
Mhm.
want to be here. Okay, good. Just making sure. So,
Then, a question I get a lot is like, what if, somebody that's younger and the parent is there, but, probably you can tell like the younger person probably maybe they want to ask you something, feel embarrassed with the parent there. So how do you
oh, we
handle
don't even have the
situations?
parents in the room. So our
Okay.
policy at our affiliate is it depends on age, but at a certain age, like you don't need parental consent to have certain services at our affiliate. So if, we have like a 15-year-old walk in and they're like, I want an IUD, it's like, great, here's the informed consent form. You understand risk, benefits, alternatives.
Okay.
You know about your medical history, just making sure that they are making the best decisions. And that is differentiates across the nation with different Planned Parenthood. So it's not like all Planned Parenthoods are
Right.
created equal. We have Planned Parenthood Federation, and then we have different affiliates all over the nation. And so, like, for example, over at Planned Parenthood Arizona, I'm not going to use the M word, the mid-level word, but PAs and NPs can't provide abortion care over in Arizona. It's only the MD. So even
Mhm.
like from state to state, the services that certain providers can perform are different. And same with age. So in like Colorado, I think like there's sometimes waiting periods. You have to get parental consent for certain services, but
Mhm.
SoCal, it's a very, yeah,
Okay.
it's great.
I just got one more question.
Yeah.
Anybody wants to take this? Is PA school really harder? I'm sorry, Mariam wants to know if PA school is really harder to get into than medical school.
I think when I got accepted to my program, I had a 3% chance of getting into my program based off of like all of the applicants and who was at the interview. So I don't know what the rates are now because I'm an old lady now that's been practicing for 8 years, but I don't know the stats right now. If you know, Kristen.
No. I would say, like, from what I've heard in the community, there's a lot of people that do think it's harder than getting into medical school, but I'm not exactly sure. James, I feel like you know this one.
Mhm.
Yeah. So I'm not going to say it's harder, but it's certainly these days equivalent. Um, while there are more PA programs, there's 338 or 339 PA programs now. So there's more PA programs than there are medical schools, but of course you have more applicants. But I would certainly say compared to what it was, my father is a doctor, my little sister's a doctor. So compared to what entry into PA school was when I went to school, it's not the same. I mean, very few schools wanted biochemistry or organic chemistry, so we didn't really have to bother with that. But I would say these days, in terms of entry requirements,
Mhm.
reality is you're doing probably all the, say, coursework that you would do as a first year med student on top of getting your clinical hours, as opposed to being a med student just focusing on the coursework. So there's a little bit of equivalency in terms of the numbers. I mean, yeah, I would still agree with that percentage wise. I mean, last year was a joke. It's not an exact number, but it was like it's what was it? It was harder to get into PA school than it was to become a pro NFL player.
Wow.
Just if you looked at the numbers.
Wow.
So, anyway, but It is, I would say, PA school is not harder, but absolutely just as hard as it is for someone to get into medical school. And I actually, and just to throw this out there, because I work with pre-PA students, I routinely get a lot of doctors from other countries that are
Mhm.
coming here and trying to become a PA because the process to become a doctor is very lengthy, even though they've already been through medical school. But last year, I don't know if you know it, Kristen, but last year I actually had a doctor, a US doctor, decide to become a PA. And it was kind of an interesting story. He had graduated medical school and had gone into research. So right after graduation, he went into research. He'd been doing that for about 20 or 25 years. But now he wants to be a clinician. He wants to see patients. And he knows he'd have to go through a formal residency. But this is a man who's a doctor. He couldn't get in. And that's how we came to meet him. He contacted us. He'd gotten some interviews. He just couldn't get past the interviews. So, I mean, we worked with him last year and he did get into a PA program, but it's even competitive for a doctor. So,
Mhm. Mhm.
Yeah.
but it's a great field.
Hmm.
Love it. You know, you'll never be disappointed going this route. I had a student, I don't know if you'd ever met him. He was doing rotations with me when I was at Escondido, and he graduated PA school, passed his boards, started practicing, I think for about 6 months, and then he went to med school.
Oh no, really?
Yeah. So that's the only time I've ever seen that. So I guess I've seen both. I've seen a PA go on to med school and a doctor go on to PA school. But
Yeah, I've had people ask me, like family members who don't understand anything about a PA, like, oh, great. Like, when are you going to med school then? I'm like, I'm not going to med school.
right.
I've been working as a PA for 8 years. What are you talking about?
Yeah, yeah. That's right.
Yeah.
Okay, well, I want to thank you for your time. Appreciate you putting this together for us tonight. For both of you, Georgina and Kristen. It's a lot of fun. And for those of you who do attend, just give me a few days and we'll go ahead and send out. We do have certificates for those who attended the hour. And I mean, we should have another virtual session coming up. So just check our social media for the next event, which should be in about 2 or 3 weeks. And that's it. So again, thanks for everybody who did attend and thanks for those who hosted the event.
Yeah. Thank you guys.
Okay.
Bye.
I know. Okay.